My name's Sin. Everyone just calls me Sin because is too difficult to pronounce. I am a consultant ophthalmologist in UHW, and my special interest is in taking care of glaucoma patients. So my job is one of those doctors to try and find the needle in the haystack. So if just a quick introduction on what glaucoma is. So what is the problem? Is it important? Yes, it is a very disease. It affects globally 66 million people, and indeed 10% of our blind registrations are from glaucoma, and it's the second most common cause for registration in the UK. If you look here, just a quick picture of a normal healthy disc on the left side is a nice donut, and then the right, it looks like the donut's been eaten up, and that is the optic nerve cable of a patient with glaucoma. And what they see is a gradual deterioration in vision. So if you look at the bottom, a normal one at the top, and it gradually crowds in and eats your vision all the way from the side. And it's what we call a silent thief of sight, because you don't know about that until it comes right in the middle, and suddenly you feel like your vision is suddenly gone. But it's not, it's been going for many, many years. Very good publicity in the BBC, where we were caught up with blindness because of our waiting times. And this is a picture of a crowded, typical eye clinic, always overbooked. We are beyond capacity, and with COVID times, this will never happen again. But this basically is the picture of all eye clinics up and down the whole country. So our main issue is lack of capacity, as with everyone in the NHS. And the problem is a big problem because a lot of patients are delayed for their follow-ups, and they should be checked, but they're not. They're getting cancelled on average at least twice for each patient. And in the National Patient Safety report, they did say that 22 patients in 2017 per month were losing sight as a result of the delays to follow-up. So we really need to do something about it. Now, how big of a problem is this in UHW? We have 1,800 patients lost to follow-up. We normally have about 900 new patients waiting to get in to eye clinic as well, and we only have 3 consultants, part-timers. So looking at the 1-year new referrals, I looked to see what are we seeing. Are we seeing people who need to be seen? And it showed that 69% of the new referrals did not have glaucoma. So these patients were almost blocking the spaces of the patients who actually need to be seen. And this is why I say I need to look for this needle in a haystack, because all these people don't have glaucoma are blocking up the spaces. So the proposed solution to this would be if we did a virtual clinic. Now, virtual clinics are not a new thing. Everyone, it's in Moorfields Eye Hospital and it's in Manchester, but it's not come to Wales quite yet. But in this case, we would see high volumes of patients virtually by senior clinicians, so that we know to discharge or not to discharge, and we would know to detect and fast track the people who actually need glaucoma treatment, like surgery and things like that. So I would want to be the magnet that sort of removes all these needles within my haystack. Now, how was I going to do it? So last year, I put out this patient workflow where basically the patient will fill out a questionnaire, they go and get their tests, so that's part of fields tests and OCT tests. It's basically capturing clinical data of their eye onto the electronic patient record, which we use. So for the glaucoma clinic, we're completely paperless. There's no paper. All data is on an EPR called Open Eyes. And this was started by a UHW nurse, where I managed to find a pre-existing nurse, beg, borrowed and steal from my sister nurse. And we got one nurse to do all the green bits, and the blue bits were done by pre-existing medical photography staff. So we made a proof of concept that it can be done. And we saw about 6 new referrals per clinic, and we only had the capacity for 1 clinic per week at that time, but we saw an extra 24 patients in a month. Now, to make that happen, to train the nurse, it takes about 50 eye pressures, probably about a month or so to do. She needed to learn how to use the EPR, the electronic patient record. We needed to look at the patient flow around the clinic just to make sure there's no patients being stuck in medical photography or in another sector of the clinic, just to make sure there's a nice flow. And most importantly, the patient needs to be kept in the loop, because most patients come into the hospital thinking they're going to see a clinician. So we made a pre-clinic visit information leaflet to say what tests you're getting done, and who you're going to see, and that you're not going to see a doctor. And most importantly, they will be fed back in good time the results of their clinic appointment, which will be in letter templates. So that would be, yes, you have glaucoma, you need to start treatment, or no, you don't have glaucoma, or you need to come back for a more thorough checkup with the eye doctor and a consultation. So once this has been set up, the next thing would be to scale it up, and this is where Bevan was quite useful. They hooked me up with a finance person within UHW, and we were going to go ahead with replacing the Band 5 nurse with a nice machine that could be operated by a Band 3 technician to sort of get the clinical data, which is eye pressure, which would hopefully allow us to scale up a lot more. However, COVID-19 hit. So there was no clinical activity for 3 months apart from emergencies, and we had a reduced clinic capacity. Obviously, we can't have those eye clinic appointment rooms again, so there was about 5 per session or something like that. However, that did push the impetus, push the care into the community. Now, this allowed me to hook onto the community eye care service. So we had funding from the Welsh government to push everything to opticians, and we call this the Community Ophthalmic Diagnostic Treatment Centre. So we would again just translate what I've done in the virtual clinic onto the community, where pre-clinic letters are given. They go to the optician. Now, the optician is not, they are well trained. They are a 4-year degree, and they do know how to measure pressures and take relevant histories. And the most importantly, they have already got the visual field and OCT machines, so we didn't need to buy any more. And all this is collated into one system. So this is pictures of the data that we look at. And this is the picture of the electronic patient record that they put on. And at the bottom screen, you'll see that they'll message me with the patient saying, this is a patient, please review. And what I'll do is I'll say, yes, you can discharge them. They don't have glaucoma, or no, they have very bad glaucoma. They need surgery. Bring them into the eye hospital. Or they have glaucoma, but they're one of those stable types where I could send them a medication, sort of an FP10, a green prescription, and a letter to their GP, and the patient can start the drops within the community and go back to the optician to get a check that the drops have worked, instead of coming to the eye clinic. And that would keep them still in the community and within that loop. So what did we see outcome-wise? Within June to 30th of September, in the 3 months, 317 patients were seen by one clinician. And we looked at, most importantly, if I draw your attention to the red one, the red is what the needles that I was looking for. So out of these 317 patients, 17% were needing either surgery or more closer follow-up, etc. So these are the important blinding glaucoma patients, and the rest were either discharged or followed up and kept in the community. So we've made sure that they've come in timely manner of about two months, less than 2 months. So the future plan would be obviously scale it up even more. This is just for one clinician, and within 3 months, we've seen an equivalent to a whole year's worth of new patients. So if more senior clinicians would take part, and also if more optometric practices were brought on board, along with IT connections and their pre-existing machines, we should be able to increase it and see more of the 900 new patients. Obviously, we always keep the patients in the loop, and out of all those 300, they've all been given questionnaires for patient feedback based on age-related macular degeneration questionnaires, and these are being analysed by a PhD student at the moment. So I'd like to thank the Glaucoma League. We have many people on board for this project. Sharon Beatty, who's the lead community optometrist, who's really holding this together, and Gareth Bulpin, who's in IT and is the project manager for this, because we need good IT connections, and Professor James Morgan, who is the EPR lead, as well as our clinical director in ophthalmology. Thank you.